Imagine, like, a deadly disease, but not just any disease. Imagine a pathogen that has absolutely no animal hosts to hide in.
Right.
It doesn't survive well out in the environment on its own. It doesn't form, protective spores to wait out the winter in the soil.
Yeah, it's fragile outside the body.
Exactly. And, perhaps most incredibly, it was successfully suppressed by a widespread vaccine decades ago.
Mm-hmm.
So by all the known rules of microbiology, this disease should be completely extinct. I mean, it should be in the history books, right next to smallpox.
Yeah, the clinical term for that vulnerability is obligate human specificity, which is, a fancy way of saying humans are the only natural reservoir for this bacteria.
Wow. Only humans.
Just us. Which means, theoretically, if we protect the human population, the pathogen has literally nowhere else to go. We have everything we need to wipe it off the face of the earth.
But it's not extinct.
No, not at all.
It stubbornly refuses to disappear. In fact, it is still circulating right now. It's actively evolving and catching our immune systems completely off guard.
It really is.
So today's deep dive is an exploration of Bordetella pertussis, which is the bacterium responsible for what you probably know as whooping cough.
Yeah, a very notorious bug.
Our mission today is to uncover exactly how this microscopic saboteur operates, why looking for that classic whoop sound is actually a dangerous misconception that might be fooling you right now.
Oh, absolutely.
And how the history of its vaccine is one of the clearest examples you will ever find of humanity and a pathogen locked in this, real-time, high-stakes evolutionary dance. Okay, let's unpack this.
So if we want to understand why this disease is so incredibly hard to eliminate, we really first have to understand the mechanics of the bug itself.
Right, how it works.
Right. And more importantly, how it attacks the human body. Because it completely ignores the standard playbook used by most other dangerous pathogens.
Well, if it's so perfectly adapted to hiding exclusively in humans, I mean, how did we finally catch it in the act?
We have to go way back to the year 1900 to find that out.
1900. Okay.
Yeah, there's a Belgian immunologist named Jules Bordet, and he's working alongside his colleague, who's actually also his brother-in-law, Octo Gengu.
Oh, nice family business.
Right. They're at the Pasteur Institute in Brussels.
Yeah.
And Bordet was the very first person to actually observe this bacterium under a microscope.
Wow.
But he didn't find it in, a random hospital ward. He found it in the sputum of his own infant daughter.
Oh, my God.
Yeah, she was severely ill with whooping cough at the time.
I can't even imagine that. I mean, you're a scientist, you're looking through a microscope at the exact organism that is causing your own child to suffer, trying to figure out what it is before it's too late.
It adds this deeply personal layer to the medical history. And the frustration they must have felt is just staggering because, seeing it was one thing, but growing it to study it.
That's a whole different challenge.
It was a nightmare. It took Bordet and Gengu 6 more years of incredibly methodical, painstaking work just to successfully culture the organism in a lab.
6 years just to grow it.
6 years. It is an extremely fastidious, picky bacterium. It will not grow on normal petri dishes.
Right.
So they finally managed to culture it in 1906 by inventing this very specific, nutrient-rich potato, glycerol, and blood medium.
Potato and blood. Wow.
Yeah. It's now called Bordet-Gengu agar. And it was so brilliantly formulated that clinical labs actually still use it today to isolate the bacterium from patients.
That is wild. So Bordet gets the whole genus named after him, Bordetella.
Exactly.
And reading through our sources on Bordetella pertussis, the actual shape of it is called a cuccobacillus, which means, under a microscope, it looks like a tiny, stubby little rod.
You're very unassuming.
Right. But what really stood out to me isn't what it looks like, it's the pathogenic strategy. I mean, it doesn't invade deep into your tissue.
No.
It doesn't breach the walls of your lungs and get into your bloodstream to cause systemic chaos like you'd expect.
Right. It stays fiercely localized in the airway.
Yeah. It is entirely focused on the ciliated epithelial cells, right?
Mm-hmm. The cells covered in tiny, hair-like sweeping structures that line your trachea and your bronchi.
So I was trying to conceptualize this, and the best way I can describe it to you listening is to think of your body like a corporate headquarters that's undergoing a hostile takeover.
Okay, I like this.
But these bacteria, the invaders, they don't even bother entering the actual building, which would be the bloodstream.
They don't need to.
Exactly. Instead, they just camp out on the front porch, which is your trachea.
Oh.
And they glue their boots to the floor so they can't be removed.
Right.
They blind the security cameras so the guards inside don't know they're out there. And then they just completely smash all the building's exterior cleaning equipment.
What's fascinating here is how precisely B. pertussis uses an arsenal of secreted toxins and adhesion proteins to achieve that hostile takeover without ever having to breach the deep tissue.
It's just chemical warfare from the porch.
Exactly. So let's break down your front porch analogy using the actual microbiology. First, the invaders gluing their boots to the porch.
Okay, what's the glue?
The bacterium uses surface adhesins, specifically two molecules called filamentous hemagglutinin,
Or FHA.
right, FHO, and protactin, that's the glue. It allows those stubby little rods to grip tightly to the respiratory lining.
Which is vital for them because normally your lungs are constantly sweeping debris up and out, right? Like a conveyor belt.
Yeah, that upward sweeping motion actually has a specific medical name. It's the mucociliary escalator.
The escalator.
Right. Those tiny hairs, the cilia, are constantly beating upward to clear out mucus and trap dust. But B. pertussis doesn't just use its glue to resist the escalator, it actively destroys the machinery.
So that's where it smashes the cleaning equipment.
Yes. It secretes something called tracheal cytotoxin, or TCT.
And TCT is basically a piece of the bacteria's own armor.
It is. It's a fragment of the bacterium's own cell wall that it naturally sheds.
Wow.
And when it releases this fragment, it is directly toxic to those sweeping cells lining your trachea. It paralyzes and kills them.
Oh, man.
Yeah, and without those cells, your airway completely loses its self-cleaning mechanism. So mucus, dead cells, irritation, it all just accumulates in the throat.
Which causes the cough.
Exactly. The only way your body can expel any of that junk is through violent, forced coughing fits.
Okay, so they're glued down. The cleaning crew's dead. How do they blind the security cameras so the immune system doesn't just come out and wipe them out?
They release the adenylate cyclase toxin, or ACT.
CT, okay.
So the immune system's first responders, the neutrophils and macrophages, they usually rush to the site of an infection to swallow up the invaders.
Right, the security guards.
But ACT penetrates these immune cells and floods their interiors with a molecule called cyclic AMP.
Okay, what does that do?
Functionally, this acts like a deafening false alarm inside the immune cell. It completely confuses the cell's internal signaling, paralyzing it so it can't eat the bacteria or call for backup.
So the guard is just standing there confused.
Pretty much. It shuts down the innate immune response right at the site of the infection.
That is just, I mean, it's incredible biological sabotage. But then there's also the namesake weapon, right? The pertussis toxin?
Yeah, the pertussis toxin, or PT, it's a signaling disruptor that actually manages to trigger a bizarre systemic effect, even though the bacteria stays on the porch.
Wait, really? Even though it doesn't go in the blood?
Right. It causes extreme lymphocytosis, which is a massive abnormal spike in a specific type of white blood cell in your bloodstream.
Oh, wow.
Yeah, infants with severe pertussis can have white blood cell counts in the tens of thousands.
That's insanely high.
It is. It's so unusual for a localized respiratory infection to cause that kind of blood profile that it actually serves as a huge red flag, finally tipping doctors off to the diagnosis.
So because the bacteria relies entirely on this chemical warfare from the surface, rather than invading the tissue, the physical symptoms in the patient build up in a highly deceptive way. I mean, it tricks the body and it tricks the doctor.
Oh, the clinical course is deeply deceptive. It happens in 3 distinct stages.
Okay, walk us through them.
The first is the catarrhal stage, which lasts roughly 1 to 2 weeks. And clinically, it looks exactly like an ordinary mild cold.
Just a runny nose.
A runny nose, a very mild cough, maybe a low-grade fever.
Wait, hold on. If it looks exactly like a mild cold for the first 2 weeks, and that's the stage when the bacteria is actively multiplying and setting up camp, then they must be incredibly contagious at that exact moment.
You hit the nail on the head. This is the central cruelty of pertussis. You are highly contagious during the catarrhal stage. You're spreading the bacteria every time you exhale or lightly cough.
Oh, no.
But you are least likely to be diagnosed because it is entirely indistinguishable from any other run-of-the-mill upper respiratory infection.
Wait, so by the time a doctor actually hears the famous whoop sound and realizes what it is, the worst of the spreading has already happened?
Exactly.
So the patient is actually less contagious than they were 2 weeks ago when everyone, including the patient, just thought it was allergies or the sniffles.
The microbiology dictates exactly that timeline. By the time you hit the second stage, which is the paroxysmal stage, the bacteria have already done their structural damage to the airway.
The cleaning crew is dead.
Right. This stage can last 2 to 8 weeks, sometimes longer. And this is when you get those terrifying coughing fits.
The paroxysms.
Yeah. The patient forcefully coughs repeatedly in a single rapid exhalation, completely emptying their lungs of oxygen. They turn blue or red in the face.
That sounds awful.
It is. And then, desperate for air, they take a sharp, massive inhalation against a swollen, narrowed airway. That sharp intake of air tearing through the inflamed vocal cords is what produces the classic whoop sound.
Because the escalator's broken, the lung cleaning mechanism is destroyed, so the body just resorts to sheer mechanical force to clear the airway.
Exactly.
Okay, so eventually your immune system does wake up and clear the bacteria out. Does the cough just suddenly stop?
Not at all. Which brings us to the third stage, the convalescent stage. Even after the bacteria are dead and gone, it takes your body weeks or even months to regrow those delicate ciliated cells and rebuild the escalator.
Because the tissue is just wrecked.
It's totally wrecked.
Yeah.
And during that time, the cough lingers and can be re-triggered by any minor exertion, a cold drink, or even just a subsequent mild virus.
Wow.
In China and other parts of the world, pertussis is historically known as the 100-day cough for exactly this reason.
100 days. Our sources make a point to bust some major misconceptions here, and I really want to highlight this for anyone listening. Relying on that whoop sound to diagnose the disease is a dangerous trap, isn't it?
It literally gets people killed.
Yeah.
Pertussis is highly fatal to infants, particularly those under 3 months old, whose airways are incredibly tiny. But infants often do not whoop at all.
Really?
Yeah, they don't have the chest strength. Instead, they present with apnea, which are terrifying pauses in their breathing.
Oh my.
The inflammation is so severe and the mucus is so thick they just silently stop breathing.
That is terrifying.
And on the other end of the spectrum, you have adults. If you're an adult listening to this, you might have partial immunity from a childhood vaccine or a past infection.
Right, so we don't get as sick.
Exactly. You rarely whoop either. Your partial immunity keeps the severe symptoms at bay, so you just get a prolonged, annoying tickle in your throat.
Which means you could be at the grocery store or holding your newborn nephew with a mild cough you think is just seasonal allergies, and you are unknowingly handing this bacteria to an infant who will end up in the ICU with apnea.
And neither of those patients fits the classic whooping cough stereotype.
Because the disease hides so perfectly during that early, highly contagious stage, doctors in the early 20th century realized that trying to cure it after the whoops started was just a losing game.
The damage was already done.
Right. The only way to actually beat this bug was to stop it from gluing its boots to the porch in the first place. We desperately needed a vaccine.
We did. And the effort to create that vaccine led to a monumental public health triumph in the 1930s.
Yes. The story of the first effective whole-cell pertussis vaccine.
Yeah, developed by 2 American bacteriologists, Pearl Kendrick and Grace Eldering. They were working out of a state health laboratory in Grand Rapids, Michigan.
The story of these 2 women is incredible. I mean, they were operating during the Great Depression in an era that offered female scientists virtually no institutional support or funding.
Very little.
They were out there doing throat swabs on sick children after their regular shifts ended.
They essentially built a massive public health intervention from sheer willpower. They ran an extraordinarily rigorous, community-based controlled trial in Grand Rapids, tracking vaccinated versus unvaccinated children over years.
Which is wild for the time.
It was. You have to remember, this was an era before randomized controlled trials were the gold standard in medicine, so their methodology was vastly ahead of its time.
And it worked.
Brilliantly. The clinical data from the 1930s proved their whole-cell vaccine worked. It eventually became part of the standard DTP shot, combined with diphtheria and tetanus. Cases plummeted globally. In the U.S., it led to a 99% drop in whooping cough cases over the following decades.
An absolute, undeniable victory.
Yes.
Until the media got involved in the 1970s and 80s.
Right. So the Kendrick-Eldering whole-cell vaccine worked brilliantly against the bacteria, but it literally contained the entire killed Bordetella pertussis bacterium.
The whole bug.
The whole bug. That provoked a massive immune response, which is great for long-lasting immunity, but it also caused frequent local reactions. High fevers, swelling at the injection site, prolonged fussiness in babies.
Which is scary for parents, sure.
And then a massive media panic set in. In 1982, a television documentary called DPT, Vaccine Roulette, aired in the United States.
I remember reading about this.
Yeah, it relied heavily on emotional anecdotes to link the whole-cell pertussis vaccine to permanent neurological injury and infant death.
It created a public frenzy. Parents were terrified that this routine childhood shot was causing permanent brain damage.
The fear was palpable and immediate. Vaccination rates plummeted in several countries. In the UK, Japan, and Sweden, uptake dropped drastically.
And the bacteria came right back.
Instantly. The biological consequence was swift. Those drops were immediately followed by massive resurgences of whooping cough epidemics, resulting in severe disease and entirely preventable infant deaths.
But the twist is, the brain damage link wasn't even real, was it? We essentially abandoned the vaccine based on a ghost story?
Unfortunately, yes. Later large-scale epidemiological studies throughout the 80s and 90s thoroughly investigated the claims and debunked the widespread causal link to permanent brain damage.
So what were they actually seeing in those kids?
The severe neurological events they were seeing were just background rates of genetic conditions like Dravet syndrome that happened to emerge at the exact same age the vaccines were given.
Oh, wow. Just a tragic coincidence in timing.
Exactly. Today, this entire saga is widely taught in public health courses as a tragic failure of risk communication. It's an example of how anecdote-driven fear can completely outpace epidemiological evidence, resulting in very real, preventable suffering.
But the public pressure and the litigation fears from pharmaceutical companies were already baked in by then.
The damage was done to public trust.
So, to appease the public fear and reduce those minor side effects like the fevers, wealthy countries in the 1990s made a massive pivot. They switched from the whole cell vaccine to a new acellular vaccine, which is the AP and the DTaP shots we get today.
Right, the acellular version.
And here's where it gets really interesting. Think about it this way. The old whole cell vaccine was like showing your immune system a full high-definition mugshot of the bacteria. Like, look at this guy, memorize his face, his height, his tattoos, his shoes, everything.
Every little detail.
Right, but the new cellular vaccine is like showing the immune system a tightly cropped picture of just the suspect's nose and left ear.
I love that analogy.
It contains just a few purified proteins, like the pertussis toxin and the protactin glue, instead of the whole killed bug.
That is a highly effective way to visualize it, because by removing the rest of the bacterial cell wall, the cellular vaccine is much safer in terms of immediate side effects.
No more high fevers?
Right, you don't get the high fevers,
Mhm.
but you are training the immune system on a much, much narrower set of targets.
So what happens to a population when their immune systems have only ever been trained on that partial, tightly cropped mugshot?
You get a massive population-level trade-off.
What's the trade-off?
Well, the cellular vaccine prevents severe disease, but its protection wanes much faster. While whole cell vaccines or surviving a natural infection give you long-lasting immunity, protection from the modern cellular vaccine starts fading in just 3 to 5 years.
Only 3 to 5 years.
Yeah, and we saw the real-world consequences of this very recently. In 2010, California suffered a massive epidemic. In 2012, Washington State declared a public health emergency. These were the largest U.S. outbreaks in decades, and they disproportionately hit vaccinated adolescents and teenagers, whose cellular vaccine-induced immunity had simply started to wear off over time.
Man. So if you're listening to this right now and you're in your 20s or 30s, the childhood shots you got are likely not protecting you from this bacteria anymore.
Most likely not.
But it's not just about the immunity fading over time. It's about what the bacteria is doing while we aren't looking. There was a study from the FDA in 2013 and 2014 using baboons that completely blew my mind.
Oh, the FDA baboon study,
Yeah.
led by Todd Merkel's group. It fundamentally reshaped how we understand the spread of pertussis today.
Can you walk us through it?
Sure, they designed an elegant experiment. They vaccinated infant baboons with the modern cellular vaccine and then exposed them to B. pertussis.
And it worked, right?
As expected, the vaccine protected the baboons from getting sick. They didn't cough, they didn't struggle to breathe. But here is the crucial aha moment for the researchers. When they took those healthy vaccinated baboons and placed them in cages with unvaccinated baboons, the unvaccinated ones got severely sick.
Wait, so the vaccinated baboons were perfectly healthy, but they were acting as hidden carriers. Like they were incubating the bacteria in their airways and breathing it out onto the others.
Exactly. The cellular vaccine prevents the deep lung inflammation and the severe disease, but it doesn't guarantee sterilizing immunity.
Meaning it doesn't stop it from getting on the porch.
Right. It doesn't always stop the infection from taking hold on the front porch. The bacteria can still survive in the upper airway of a vaccinated individual for weeks, just silently multiplying.
That is a terrifying concept. Silent transmission.
It really is.
It means you could have a population of completely healthy, vaccinated humans walking around feeling perfectly fine, not coughing at all, but silently spreading the bacteria every time they speak or laugh.
And because we're only training the immune system to target specific proteins, that cropped mugshot, the pathogen is actively exploiting our narrow focus.
Oh, because it's evolving. The bacteria is looking at the partial mugshot we're using and deciding to get plastic surgery.
That's essentially what is happening on a genomic level, yes. Because the cellular vaccine heavily targets the protactin protein, we are now seeing circulating strains of B. pertussis in the US, Australia, Europe that have simply dropped protactin entirely.
They just stopped making it.
Yeah, they're called protactin-deficient strains.
Yeah.
The bacteria just stops producing one of its own surface proteins because it realizes that's exactly what our immune system is looking for.
It's literally shedding its own nose and ear so it doesn't match the mugshot anymore.
If we connect this to the bigger picture, it is a prime, real-time example of vaccine-driven pathogen evolution. When you have a narrowly targeted vaccine, you exert immense selective evolutionary pressure on the organism. Strains that don't produce the targeted protein have a massive survival advantage in a highly vaccinated population, so they rapidly become the dominant strain.
Okay, if the bacteria is actively evolving to hide from the vaccine and healthy vaccinated adults are silently spreading it without even knowing they're sick, how on earth do we protect the infants?
It's the ultimate challenge.
Right, because they're the ones who face the highest risk of death, but they are too young to even get their first vaccine doses. We can't rely on herd immunity if the herd is silently contagious.
We can't.
Uh,
And it comes down to a harsh numbers game. Epidemiologists measure how contagious a disease is using a basic reproduction number, or R naught.
okay.
Pertussis has an R naught of roughly 12 to 17 in a susceptible population.
12 to 17. That means one infected person will, on average, infect 12 to 17 other people.
It is insanely contagious. It's on par with measles and vastly more contagious than influenza or most variants of COVID-19.
Well,
Because the R naught is so incredibly high, you need massive, nearly universal herd immunity to stop community transmission. But since we know a cellular immunity wanes and silent transmission happens, the wall of community herd immunity is basically full of holes.
so what's the backup plan?
Public health officials have shifted to a much more targeted strategy called cocooning.
Cocooning, like building a physical wall of immunity directly around the baby.
Precisely. Since we cannot vaccinate the newborn directly during those fragile first few months, we aggressively vaccinate every single adult who will come into contact with them.
Parents, grandparents.
Caregivers, older siblings. You ensure they all have fresh booster shots to create a protective cocoon of active immunity around the vulnerable infant.
And reading through the current guidelines, there's also the strategy of giving the baby a head start before they're even born, right?
Oh, this is perhaps the most crucial modern standard of care in prenatal medicine. We now administer Tdap booster shots to pregnant women during every single pregnancy, regardless of when their last shot was.
Okay, why during pregnancy?
By timing the booster perfectly, usually early in the third trimester, the mother's immune system produces a massive spike in protective antibodies.
Oh, and those cross over to the baby.
Yes, those maternal antibodies are actively transferred across the placenta into the baby's bloodstream before birth. So when the baby takes their very first breath, they already have a temporary borrowed immune defense waiting in their airway to protect them until they are old enough to get their own shots.
It's a brilliant workaround, but it's also a constant, exhausting maintenance effort. We're just holding the line.
We are, and this raises an important question for the future of public health.
No.
How do we continue to manage diseases when both our medical tools and the pathogens themselves are in a constant state of change?
Right.
The shift to cellular vaccines in the 90s solved a safety and public trust issue, but it created a durability and transmission issue. We are currently managing that trade-off with rigid booster schedules and cocooning, but the evolutionary clock is always ticking. The bacteria is always adapting.
So what does this all mean for you? If you step back and look at the whole picture, B. pertussis is a brilliant biological saboteur. It's a human-only pathogen that completely refuses to enter the bloodstream, relying entirely on a sophisticated toolkit of chemical weapons to break your airway's cleaning system and deafen your immune response.
Beautifully summarized.
It tricks us by hiding its most contagious phase behind the symptoms of a mild cold, and it completely defies the classic whooping stereotype in the adults who silently spread it and the infants who are most threatened by it. We are currently locked in an evolutionary dance with it, using our cropped mugshot cellular vaccines to try and keep it at bay, while relying on strict booster and cocooning strategies to protect the most vulnerable among us.
It's a delicate balance.
But I want to leave you with a final thought, a question really built purely on the biology of this bug we've uncovered today. As we discussed, the bacterium is currently dropping the protactin protein to hide from our modern vaccines. It can afford to lose that specific piece of glue, but it still absolutely requires its primary glue, the filamentous hemagglutinin, to stick to the airway. And it absolutely requires its cilia killer, the tracheal cytotoxin, to stop the lung from sweeping it away.
It can't live without those.
It cannot survive in a human airway without those core biological weapons. So, if scientists can design a next-generation vaccine that perfectly targets those specific non-negotiable weapons, the ones the bacteria cannot afford to drop without dying, could we finally capitalize on its fatal weakness? Could we use its human-only status against it and finally push Bordetella pertussis into the exact same grave as smallpox?
That is the ultimate goal.
It's something to think about the next time you or someone near you has a lingering cough.